Welcome everyone to the April 23rd COVID-19 clinical care rounds focused on emergency department care and clinical operations. My name is Richard Hunt. I'm an emergency physician serving as Senior Medical Advisor at the National Healthcare Preparedness Program in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 emergency department challenges and successes in patient care and operations. If I'm an emergency physician preparing to care for many COVID-19 patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated. These rounds are not intended to be redundant or replace any organization's initiatives in response to COVID-19. It is intended to be a sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care with other clinicians. These rounds, in many ways, are similar to what military medicine did in Iraq and Afghanistan to identify what works and what does not work, refining it over time and embracing a culture of continuous improvement. That resulted in the lowest case fatality rate for U.S. service personnel recorded in the history of war. These rounds are tackling our current war against COVID-19. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all noon Eastern Time in the United States. Monday, April 27th, noon Eastern Time, we will have clinical rounds on EMS patient care and operations. Mondays will be EMS, Tuesdays critical care, and Thursdays emergency department. When we send out announcements for upcoming rounds, at times you will not see speakers. They will be to be determined since we work to identify speakers just in time, given the rapid changes and experience with the pandemic. For the ECHO clinical rounds we've had to date, we've had participants from many states and many countries, predominantly physicians, nurses, and EMS clinicians, but other disciplines have also been represented. We've noted continued interest from many countries. This disease knows no boundaries, and it's gratifying to see clinicians from across the globe learn from each other, always focused on the patient. We're interested in making this more interactive by engaging expert discussions and crowdsource polling. We receive many pages of questions. For this one, we received 89 questions and pressing needs. And we apologize in advance that we're not able to answer all of those. We've picked out some major themes from those questions, and we'll try to address some of those. At this point, I'd like to turn this over to Dr. Bruce Struminger for some housekeeping and introduction to some of our polling and chat room functions.
Great, thank you, Rick. I also want to extend a warm welcome to the over 550 participants who are joining us today for this peer-to-peer learning experience. So a few housekeeping items. There's a Q&A function in the bottom Zoom bar for questions and comments regarding the presentations, and we really encourage you to ask questions there. We're going to reserve the chat function for questions regarding technical or logistic issues. We're also going to verbally ask you a few questions and put them in the chat that we're hoping to crowdsource. And we're trying to get voices from the field and in local experience, so please share that with us. The session is being recorded and your attendance is consent to be recorded, so thank you for that. The slides and a link to the video recording will be shared after the session via an email with everyone who registered. They're also going to be available through a link to our website that has the recordings and the PowerPoints for the last 5 weeks. We'll share that as well. There will be CME and continuing professional development credits available through the University of New Mexico. There'll be a link in the chat at the end of the session, and I believe we have a link in the most recent email announcement. You'll get CME and CPD, and we will receive feedback on how these sessions are going so we can improve them. And with that, I am also going to go, I'm going to ask Rosha at AAMC to highlight the clinical guidance repository. Rosha?
Yes, so I'm very happy to let you know about the ongoing resource we have at the AAMC, which is the Coronavirus COVID-19 Clinical Guidance Repository. We did change the name slightly. The URL is the same, but we've heard that people are searching using coronavirus. We have a lot of new guidance from specialty organizations. We're about to put up some alignment guidance where we show similarities between the guidance from different institutions and subspecialty organizations. So we hope you'll visit and hope it's useful for you, for clinicians.
Great, thank you, Rosha. And Rick, I'm going to go back to you to share these crowdsourcing questions that I'll then later put in the chat.
Great, thank you. We've actually learned a lot from each other and been able to actually forward some of the responses to these questions to leadership here at HHS and at FEMA. So these are actually important for us to all learn from your responses. So highly encourage you to respond to these. First question, what is the unique medical equipment and supplies you are using for high flow nasal cannula oxygen treatment of COVID-19? Second,
Rick, I think your internet may have slowed down a little, so I'll go ahead and jump in and ask the second question. Should high flow nasal cannula equipment and supplies be added to the strategic national stockpile? That's the second question. The third question is, are you noting social and racial disparities among patients presenting with COVID-19? And then please tell us what state or country you are in. And it looks like we may have lost Rick there oh, Rick is back, excellent. Rick, you are muted, so please go ahead and unmute. There you go.
thanks very much, all. Appreciate your patience. At this juncture, I want to go ahead and introduce our speakers and panelists. We're just going to go around the table very briefly with your name, title, and affiliation, please. Carrie. And if everybody would unmute yourselves now, that will make it much faster to go. Thank you.
My name is Carrie Scannelberry. I'm an emergency medicine physician at Inova Fairfax Hospital in Northern Virginia. I'm also our lead physician liaison for emergency preparedness for the Inova Health System.
Dave and Jeff.
I'm David Barron. I'm an emergency physician, and I am the medical director of the emergency department at UMC Hospital in New Orleans.
Jeff Elder, I'm an emergency physician with LSU Emergency Medicine, and I work clinically at University Medical Center. I'm the medical director for emergency management.
Sharon.
Sharon Van Eersdale. I'm the program director for Emory Serious Communicable Diseases Unit. I'm also the director of education for the National Emerging Special Pathogen Training and Education Center.
Sandy.
I'm Sandy Schneider. I'm the Associate Executive Director at ACEP for Clinical Affairs. I'm also a practicing emergency doc at John Peter Smith Hospital in Fort Worth.
Rosha.
Hi, I'm Rosha McCoy. I'm a Senior Director of the Association of American Medical Colleges. I'm a pediatrician by training and work on quality and clinical leadership.
Paul may have frozen.
Nope, sorry,
there you
Rick, I
go.
didn't hear you call my
That's all
name.
right. That's okay.
Paul Biddinger, I'm an emergency physician. I direct the Center for Disaster Medicine at Mass General Hospital in Boston, and I'm medical director for emergency preparedness for Mass General Brigham Healthcare.
Thank you. Eric?
Hi, everyone. Eric Way, Chief Quality Officer for New York City Health and Hospitals, and a practicing emergency medicine physician at Kings County.
Thanks, Eric. And Eric recently co-presented at a recent emergency department rounds. With that, I'm going to go ahead and introduce our first speakers, Dr. David Barron and Dr. Jeff Elder.
Hey, Rick.
Yeah, sorry.
Take 1 minute. We'll do that poll.
Sure.
Question.
Yeah, a pause. Just hang tough.
Great. So Amanda, if you can launch that poll. We're going to be doing a little pilot of crowdsourcing through a poll rather than through the chat. And here's the question. Over the past 7 days, is your access to PPE while caring for patients better, worse, or the same? And the way to answer that is to either text Project Echo D101 and then put in A, B, C, or D, or go probably better to pollev.com/Project Echo D101 and enter the response. Amanda, anything else we should add to the directions there for people? You're able to come on, that'd be great.
You covered it pretty well, thank you. Just a note that the Project Echo D101 is all one word, but capitals or lowercase doesn't matter if you're texting. And you can also go to justpollev.com and then enter Project Echo D101 as your keyword. And this will continue to remain open even after we've taken it down. So if you're in the process of responding, please continue even if you don't see this on the screen anymore.
Great, and we'll put that link in the chat, and maybe Amanda, we can stop sharing for now and go back to Rick.
Yeah, and Bruce, I think in between speakers, let's put that screen up again for just a second as a good reminder. So back to introducing our first speakers, Dr. David Barron and Dr. Jeff Elder. Dr. Barron is affiliated with LSU New Orleans and is the medical director of the emergency department at the University Medical Center in New Orleans. Dr. Jeff Elder is a clinical associate professor at LSU Emergency Medicine and medical director for emergency management, University Medical Center, New Orleans. With that, it's my pleasure to turn it over to you two gentlemen.
Okay, thank you. So to kind of start out with a profile of our emergency department so you get a sense of what we're working with from a resource perspective as we went through this pandemic is we're a level 1 trauma center. We're an independent academic medical center. We're affiliated with both LSU and Tulane. We have both residents and students coming through our ED all the time. We see about 90,000 patients a year, and we ordinarily admit around 17%. We've got 50 beds, 9 fast track beds, 20 behavioral health beds, with both 104 hours of physician coverage and about 48 hours of APP coverage a day. So it kind of gives you a sense with what kind of ED we're talking about when we talk about our responses and our successes and challenges. So this just kind of gives you an idea of what's happened with our volume through this time. Our first case at UMC was on March 10th. And so you see our normal volume over here on the left-hand side of the screen is about 250 patients a day. And the greenish line is our admit rate, which is around 17%. We have a forced isolation order that happened on the 24th of March, and then you see what happened to our volume. So we lost about 100 patients a day, and our admit rate went up to around 25-ish% per day. So a little higher acuity, a little lower volume, and it's because of that that we ended up with a lot of opportunities and flexibility for staffing, where we can move people around as different kind of needs came externally to our emergency department. The magenta line on the bottom shows you the actual number of beds that we were requiring. So even though our admit rate went up, the actual number of beds that ED was demanding stayed about the same, or actually went down through this time period, even though the acuity changed. This is a busy slide that I included more for people to look at afterward if they want to come back to the presentation, but it shows all of the different interventions the ED has made over the last month and a half, roughly, from the time of our first COVID patient on the 10th of this month. And we'll go through some of these things as they have presented successes or challenges to us. So at UMC, I think one of the big things that we've seen as a success has been the morale of the people that work here. Administrators walking through the ED have commented on this. Multiple levels have seen that we have a very resilient, very flexible group of people. And many of these people have been through Katrina, they've been through other public health disasters, other hurricane storms, and they understand and are comfortable with the idea of uncertainty. And so because of that, from our techs and our nurses and everybody at UMC, we have a very resilient group of people that's very willing to be flexible with where they work, how they work, and when they work, and have a very good attitude about this. And to me, this has been one of the successes one of the reasons for the successes of the different interventions that we've made, is just the team that we have working here. Our communication, we started twice daily incident command meetings very early on. And one of the successes we've had has been taking that information and sending it out to everybody involved. It's just helped dispel a lot of the myths and a lot of the anxiety surrounding this. So the questions of how many vents do we have? Well, I can tell you exactly how many vents we have twice a day, or how many beds we actually have. So as people became very concerned about rationing and the acuity of the patients, they had something to fall back on that streamlined those communications from multiple sources at least twice a day. And that, I think, helped dispel a lot of the anxiety surrounding this. It also gave people a chance to feedback and ask specifically, what about this or what about that that's not mentioned in these briefings? And so we've done, I think, as a team, a great job of constantly communicating everything we know from one source of truth as it comes to the emergency department. Telemedicine has been a success. So we didn't have this before. Our first case was on March 10th. Our first provider was out on quarantine by March 11th. And so at some point we peaked with about 7 providers out at one time that were either quarantined or were somehow symptomatic. So if they were able to, telemedicine kept those people employed, it kept patients seen, they were doing teletriage, they were doing a hotline, they were providing care from home or from the ED as a telemedicine service. That was a benefit to the patients and to our hospital and to the providers, and we're calling that a success. We also use telemedicine in the ED to limit PPE usage, so iPads in the room with the patients. And then we exported some of these processes to the med-surg floors and to the ICUs. So end-of-life care discussions, patients that are on, that can't have visitors at this time, able to see their families, all those things we addressed with telemedicine and have been successful with that. Our system leveraging, so of our 5 adult hospitals in our system, we're kind of the big one and the resource-rich one and had more capacity. So we've been able to do a lot with transferring patients in and decanting other adult emergency departments in our system to keep their flow going. So we come up with a new process for ED to ED transfer and then ED to floor transfers to keep those other emergency departments and other floors flowing with patients. And for a system level, that's been a success that our ED could take part in. And then the support of UMC. So, you know, having 2 major medical schools here and then having UMC independently means that there is a lot of structure and a lot of organizational kind of barriers and silos that have existed. And through incident command and through a lot of other meetings, we've broken down a lot of that and have had a lot of opportunities to get with other people, make protocols that work, make protocols that streamline patient care and get people cared for in a much smoother fashion. And for a lot of these specific cases, administration has been very supportive of that, again, through incident command meetings, identifying what resources that we need and helping us to get those resources to get the patients cared for. So I think in terms of the buy-in across the board, we've had a lot of successes at UMC, and a lot of that has been through the venue of multiple meetings. Our big challenges have been, number one is data. We usually have a problem with data, but now just getting on a regular basis data that we know is actionable and data that we know is accurate has been an ongoing issue. So we wind up pointing a lot more to data trends than actual numbers of things and kind of getting an idea of where things are going. But just getting real-time data that everyone can agree upon has been a challenge. Communication, also a challenge as well as a success. So everyone, I'm sure, is seeing that when you have the CDC and you've got the system and you've got experts and you've got your hospital, all these different people that want to weigh in, taking that information and synthesizing it into a package that's usable by the right people, even though it's been a way we've been successful, it's also been a constant challenge because you're kind of just sort of roping people in constantly to make sure that the message is similar. That's been an ongoing dilemma for us. We've lost nurses, we've lost doctors, and we've lost APPs to other endeavors. So other hospitals, to our convention center, to locum tenens, to traveling nursing, all that stuff. The best and the brightest and the people that want to be engaged and they want to be a part of the disaster response are attracted to that, and multiple people have left. And so that's been kind of an issue in the emergency department, which we've been able to compensate for because the volume's been lower. We've been able to keep up that difference and keep a ratio that works for us, but it's definitely something we have to consider for future pandemics. And then lastly is structure. I think when New York gave the presentation before, they had that slide that like everything is planned until you get punched in the face. And it's the same thing here. We have this structure that works until COVID comes around. And so trying to get past some of those institutional barriers to some of the culture and culture of some of the services coming through the ED, getting beyond that, and some of the has been a challenge, but I think that through some of the venues that we've established, we've been able to get beyond that and make protocols that work for the patients from the ED side. But Dr. Elder's been a critical component of the incident command structure, and so he'll do the second half of the talk.
All right, so as far as emergency management, like, most hospitals, we have, planning for pandemics that, again, for a lot of people, we use some of this during H1N1, and then kind of we have a plan on the shelf, and that's kind of what we've had. And that's kind of been a go-to for, when people, ask about, hey, what's your plan? Obviously, when this all kind of started, and we started seeing the reports from China and the WHO and the CDC started talking about this, early in the year, we kind of, took out our plan and started dusting it off, and kind of started looking at, how can we tweak what we think we need to do for coronavirus. And this was before it even really had the name that we, call it today. We did come up with an ED patient under investigation evaluation process. And this was during the days of, really travel-based cases. So you had symptoms plus some travel, and then that would kind of trigger you to be screened in the emergency department. And so, we had that ready. And then I was working a shift towards the end of January, and this was actually January 26th, when we had a call from a clinic from someone who had come off of a cruise. They had been in Asia, kind of been Hong Kong, and all around multiple different spots in Asia, and were back and had symptoms that were consistent with COVID. And so luckily we got that phone call that gave us a heads up that this person was coming in from home to be evaluated in the ED. So that gave us some time to really put our plan into effect. And on that first day, we saw our first patient under investigation. And so we evaluated the patient. We tested per our state OPH lab at the time, which was the only test available. And luckily, we were able to send that person home, and they were ultimately negative. But after that happened, that really had the hospital kind of step up our preparation. So where at first it was kind of more focused to what was happening in the ED and how we would catch these patients when they presented to the hospital, we had a SARS coronavirus specific work group that got together, and this was the CMO, emergency medicine, emergency management, infectious disease, critical care, the hospitalist, all meeting, multiple times a week to really kind of bolster our plan. And these were set meetings, it was continuous, and we really kind of continued to work on what we were doing to prepare for what was going to be likely more patients. Here you can see kind of a timeline of kind of the things that I've been working on the emergency management side. And I think if you look at the top, you can see that initial, planning and the initial patient evaluation that we had in January. And then we luckily had, 5 or 6 weeks up until the 10th of March when we had our first positive case here at UMC. In New Orleans, there was a initial positive at the Veterans Affairs VA hospital right next door to us the day before. So we kind of knew this was probably coming. We had some pending tests from the state. And on the 10th, we had our initial positive. And then this really, started our quick uptick in patient presentations, patients under investigation with testing that at the time required us to send labs to the state Office of Public Health lab, which was a bit of a process. So that required us in the ED getting on the phone, talking to someone, getting approval for testing. And so it was a little bit of a drawn out process, but that was, again, our initial workflow. So for the system, as David said, UMC is part of a 5-hospital system. We have a children's hospital as well as 4 adult hospitals, community-based, academic, and kind of everything in the middle. And so when we had that first positive on the 10th, that's when we stood up officially our incident command. While we had plans to do this and we were ready to go, once we had our first positive, that's when we flipped the switch. And we both stood up incident command at the hospital with the hospital leadership, so the CEOs, CMOs, and their internal incident command structure, as well as at the system level for an overall unified command for LCMC Health. And so, there were a few things that we really started to have to work on right off the bat, right? And so initially it was standing up those teams, making sure we had the right people in the right spot for incident command. And there were things that we had to really get moving fast. Testing was obviously a big one for everybody. For us, it really started at the Office of Public Health for the state. That was our initial testing modality. Within a week or so after that, we had commercial testing that came available. And we had a lot of delays, to be honest with you. We had testing that was taking 7 to 10 days if it was sent to a commercial lab. If it was sent to the state, it was taking a few days. And we had to really work on system-wide how we were getting these lab tests to the lab and then ultimately back to the individual hospitals, to the providers, and then giving results to patients, whether they were in the hospital or at home. And so we came up with an entire process to track all of this. That was a centralized system-level process, and then have the ability for people to call patients that were sent home from the emergency departments with their test results. And then finally, this month, we're able to get in-house testing going on up to 3 different modalities. So we now have Abbott, Cepheid, and Roche testing modalities at our different hospitals. That's given us a lot more capacity to move through that. Additionally, we worked on clinical workflows, whether that was the hospitalist or the ICU or in the ED. And really, this was just kind of learning how to care for these patients. Initially, everybody was, of course, very nervous, and how do we deal with this, and what are we doing? And it came down to good supportive care and good evidence-based medicine for that supportive care. And I know Dr. Jans with our ICU talked about this previously through these podcasts. And that really allowed us to kind of set out what we were going to do moving forward. That included, adding additional ICU teams, not only our medical ICU critical care physicians, but our surgical ICU critical care physicians here at UMC stepped up, and we're seeing COVID patients primarily in the different ICUs. And so that gets into our facilities. Across the system, we stood up an additional approximately 75 ICU beds. We were able to take an area here at this hospital, create an entire floor and transition it to negative pressure, which allowed us to expand greatly our ICU capabilities, and then use other areas like the PACU or other floors for both med-surg and ICU beds. And of course, the big one for everybody was PPE conservation. So we really worked as a system on how we would roll that out. Being a system really helped us on the supply and logistics side, because we were able to leverage a lot more buying power as a system to go out and search for PPE than we would have been able to do on our own as individual hospitals. For us, our big peak was around April 1st. We had around 400 COVID patients in the hospitals across the system, and it was about 55 to 60% of our total patient population. Luckily now today we're down, our vent use is down to about 1/3 of what it was at its max. Overall, our ICUs are down about 30% with COVID patients as before, and we're down to about 220 COVID-related cases in the hospital today. Sorry, and so You know, one thing you've seen a lot in the news here is we had the Memorial Convention Center set up a medical monitoring station. One of our faculty members, Dr. Megan Maslanka, who did a disaster medicine fellowship up in Boston after she trained here as a resident, was asked to lead that area as the medical director. And so she was able to help stand up a 1,000-bed facility in literally a matter of about a week and a half to 2 weeks that opened in early April. Fortunately, they only had to use about 100 beds, and they're really using this to allow the hospitals to discharge patients who need kind of low-level care. A lot of these have turned out to be actually nursing home type patients that we couldn't either get back to nursing homes or couldn't get back home and still required isolation. And so that's helped the hospitals greatly. And luckily, we haven't needed the numbers that it was initially set up for, but I think that was just good early planning from the state to make that happen. I will say this, as emergency physicians, whether you're at a large academic hospital or a small rural hospital in the community, I do think that having your physicians kind of embedded in local government and just emergency planning for whatever your system looks like is extremely beneficial. We have emergency physicians from this hospital that work with the Office of Public Health at the state level. One of our faculty physicians is the director of the New Orleans Health Department. We have ED physicians at high levels with the system, with IT, emergency management, and then of course the emergency departments. And having people engaged at all those levels really allows the emergency medicine folks to kind of drive a lot of what we're doing in this emergency disaster response. And then finally, moving forward, you know, for us at this point, while our numbers are coming down and kind of leveling off for now, we're looking at kind of what are our next steps. And so this week we started community partnership testing with LSU Health Sciences Center and the New Orleans Health Department, along with LCMC Health. So we're actually doing testing in the community with walk-up testing sites. So that's increasing our statewide numbers for testing for PCR. We are currently working on a process to bring back emergent or urgent surgical procedures. The fact that the state acted early to kind of slow that down really helped us with our volumes in the hospital. And so now we're looking at how we kind of turn that back on, while at the same time we're planning for, you know, are we going to have additional cases? So at some point, you know, as the economy opens back up, we're going to have more people out there. And so we have to be ready for whatever is to come. We don't want to see more cases, but I think we have to be ready for it. And then finally, I'd just like to say that, you know, again, having people, you know, engaged with the right agencies, whether they're our faculty who work with these other agencies, or just having those good relationships in the community with both government and the healthcare side, I think has helped us really drive our care forward. We've had great, you know, leadership at the state level from the governor's office and Department of Health. That's really just made our job a lot easier, you know, as we move forward.
Thanks very much, Dave and Jeff. Really appreciate the presentation. I have a question, one question, but I want each of you to answer it. We'll see if there's concurrence. That time was impressive. It was like the third or fourth slide, I think Dave showed. And
Yeah.
there were a number of, it was like, okay, these were the big picture things that we did through this response. So whichever one first, which of those interventions do you think has made the most positive impact on your ability to respond to COVID-19?
Start from the system.
Yeah, don't everybody go first.
Yeah, whatever
Yeah.
you say, I'm just going to say I
Yeah.
concur.
So I think, you know, the biggest piece to this is, you know, in New Orleans, unfortunately, we've been through some things like this with our healthcare system, where we've kind of been forced into some disaster mode. And I think the most effective thing for us is the fact that we have a really good ESF8 system set up in the region, that we're communicating with not only our hospitals, but with the state and the other system hospitals, right? So the people who are traditionally our competitors in healthcare, we're working with them because we've kind of been through this before. And so a lot of people through communication kind of know each other and are able to talk and make things happen, I think, a lot quicker at a much higher level. And that's just talking from that kind of the system level.
Yeah, sure. Dave, what do you think?
Yeah, I think that a lot of these individual interventions that you're seeing on that timeline I think a lot of people are doing them, and you're talking about these sort of events, but the events by themselves, I don't think would have been successful at all if it wasn't for the flexibility of the people that we have here in terms of the actual individuals and the team that we have. For the reasons that Jeff is saying, they're used to this. They understand the concept of uncertainty and their willingness to flex, like for example, into a tent. So you see the tent on that list. Well, the tent by itself, we maximize that, not inherently because of the tent, but because of the people that were able to make it work. And I think that the team and the individuals have been, through all those interventions, the glue, the driving force for the success we've had here.
Great, thank you. As Bruce, I'm going to tee you up to put the polling question up. And want to highlight, as he's doing that, comment that was made during the New Orleans presentation about Dr. Jantz's presentation. We had a clinical rounds on critical care. It was a special session on ventilation support strategies. In the announcement that you received about those for these rounds, you'll see a link to that special session. I highly encourage you to view that really important critical care special session on ventilation management strategies. It really is major advance in how we're working on supporting these patients. So with that, Bruce, turn it over to you for a second, and then I'll introduce our next speaker.
Great, thanks, Rick. So I think what you're asking is for us to share the results of
the poll questions anyway.
Okay. So Amanda, if you can maybe share your screen. So here, we're actually going to share the results so far. And the question is, over the past 7 days, is your access to PP while caring for patients better, worse, or the same? And for most, we're seeing the same, but right behind that actually is better. For those who have not had a chance to reply, and I think we've had about 120 or more replies, we'll put the link in the chat so you can join and offer your input. With that, Amanda, I think we can stop sharing and let Rick introduce Carrie. Go ahead, Rick.
Carrie, I'm going to do an abbreviated introduction, so we give you time. Dr. Carrie Scantlebury is an emergency medicine attending at Inova Fairfax Hospital. She's the lead physician advisor for the Inova Health System Emergency Preparedness and Response. Carrie.
Thanks for having me, Rick. I'm going to go ahead and share my screen here. So just to give a little bit of lay of the land, Inova Fairfax Emergency Department is in Northern Virginia, located in Fairfax County, Virginia, with a total population of about 1.2 million. And we're just on the outside edge of our nation's capital. The Inova Health System has approximately 5 hospitals with associated freestanding emergency departments, primary care, ambulatory surgery centers. Inova Fairfax Hospital is a level 1 trauma center, stroke center, STEMI center, and a 923-bed hospital. Associated Teaching Hospital with George Washington University, Georgetown University, Virginia Commonwealth University, and UVA. Our emergency department layout is there on the side. I put that up there to kind of give people an idea of how our emergency department is laid out and how we're best operationalizing those things that we have lessons learned from prior presentations and kind of the unfolding of this situation. Overall, our volumes have decreased since mid-March. Our first positive case was noted to be in early March. Once we hit mid-March, we started getting a definite decrease in all complaints, presenting both by EMS and walk-in through the front door. Over the past 2 weeks, we have had a notable increase in respiratory complaints and fevers, with a larger proportion of those patients that are being admitted. Our emergency department in routine operations is split into a north side and a south side. That south side tends to get our more critical patients. That's where our trauma resuscitation bays are. That's where our STEMIs go through. Our strokes are primarily seen on the south side. The entire department is staffed by the same group of physicians, so there's no difference in terms of which physician is on what side. What we're trying to do as we have been approaching this current situation is we're trying to sort out our patients into respiratory complaints and non-respiratory complaints, and trying to cohort those respiratory complaints isolated to one particular area in our emergency department, because we do have that geographic setup. So we deployed a tent at the drop-off area outside our front door to our emergency department. We've also expanded our urgent care assessment area into the waiting room and kind of cordoned off our waiting room into two separate areas. So what we're doing is we're splitting the flow. Our initial contact with our patients is done in a tent outside of our front door. At that tent is where we're deciding whether or not patients have respiratory complaint and or fever or non-respiratory complaints. In that tent is where all patients are also given a surgical mask to wear. Given our geographic area, we have a kind of interesting, we have patients presenting from Maryland, patients presenting from Washington, DC, and patients presenting from Northern Virginia. So depending upon where they are coming from and what their local law or recommendations are, some people are presenting with already wearing face masks, some people aren't, some people are wearing bandanas. So what we're doing is at the door, everybody is given a surgical mask to wear and asked to keep it on for their duration of their visit. Those patients that aren't there for respiratory complaints or fevers are labeled category A, and they proceed through our typical flow of first look and triage, and then slotted to a room in the back. Those patients that are there presenting with a respiratory complaint, whether it's fever, cough, shortness of breath, are labeled our B category. And those B patient pathways, we kind of take a different route with them. We still do our first look and our vital signs at triage. We have also added in an ambulatory pulse ox reading at that initial first look and triage point. Those patients that have stable vital signs with a stable ambulatory pulse oximetry rating that is reading above 93% are actually slotted to a waiting room spot and seen by either a mid-level provider and a physician. They're in the waiting room. We've also staged a portable x-ray machine and stocked them with flu swabs there in the waiting room, so that way we can try to rapidly evaluate and discharge those patients from the waiting room without ever actually bringing them into the core of the ED. Those patients that either have unstable vital signs with a ambulatory pulse oximetry reading that's below 93% are brought back to the south side of the emergency department. Basically, what we're trying to do is cohort those patients, and we're slowly growing this pod. We've started with 2 pods on the south side, which is now slowly encompassing all of the south side. If the process continues during our surge, we will add a pod to the north side and start moving non-respiratory fevers and complaints over to an outlying surge area that we've identified and have staffed, but haven't quite reached that volume yet of where we need to surge into that overflow space. If a patient that is being brought to the back is likely to require a procedure that's been deemed higher risk for aerosolizing the virus, we have been placing them in a negative pressure room. If they're in that in-between where they're not requiring a negative pressure room, but yet at the same time still needing to be evaluated, we're keeping them on droplet and contact precautions with surgical masks in a regular room with the door closed. Again, we're making sure that all of our patients have surgical masks from the moment they walk in the door and keeping them on throughout the duration of their stay. We're also doing that with our EMS providers. Most of our EMS providers are bringing those patients in already with a mask, but if they do not have a mask on, we have a mask cache of masks basically left at the front ambulance bay that they can bring patient in, pick up a mask if they don't have one, and apply it to the patient prior to entering. Again, we're trying to cohort those patients together just in effort to minimize exposures to our providers, other patients, and while most effectually cohorting our PPE supply also. So for our codes and full activations, we are using a full level of PPE, whether it's an N95, PAPR, or equivalent respirator in all of our cardiac arrest patients and all of our trauma activations. We are using a Lucas device for all of our CPRs. Our intubation in respect to the cases that are being intubations, we are using primarily GlideScope for the procedure. We're also using plexiglass intubation boxes, and we have created a team, thankfully, with our very helpful intubation or our anesthesia compadres, an intubation team that is on call 24/7, who are more than willing to come down and intubate any of our COVID-19 suspected cases in the emergency department. We're also screening all of our STEMIs prior to taking them to the cath lab. We're screening them for fevers, coughs, shortness of breath, and also reviewing recent contacts in terms of anyone in their recent contacts, house, anybody else with fevers. In terms of clinical considerations, we're sending the typical flu, CBC, comprehensive lactate, troponins, getting EKGs, chest x-rays. Our inpatient counterparts are also looking and trending procalcitonin, CRPs, ferritin levels. We're limiting our fluid restrictions. We are starting to prone patients in the ED for an attempt at hopefully avoiding intubations. And we are, much like everybody else in our region, favoring chest x-rays over CTs and trying to limit our exposures of taking patients to the CT scanner. In terms of those patients that are stable enough for discharge, we are scheduling follow-up phone calls, and we're heavily relying on and incorporating our community providers in order to follow up on these patients that are kind of on that border where they're not sick enough yet to be hospitalized, and making sure that they don't need to come back in for a reevaluation. For those that don't have primary care, we are incorporating our hospitalist and our transitional clinic providers to help us with this. We are discharging some patients home with proning instructions. Some patients are also going home on antibiotics, albuterol inhalers, and obviously instructions for self-quarantining. One of the other areas that we ran into issues, much like I think probably most of us across the nation have run into, our testing flow changed over time, which as things become more available, we're testing a larger cohort of patients. Initially, we started with the Virginia Department of Health guidelines for testing that were guided by the CDC. We then got LabCorp available, and then Quest became quickly available about a week after that. Currently, we have both Quest and in-house testing available. The Quest testing turnaround time was about 3 to 4 days. Initially, we were only using the Quest testing for those that were admitted to the hospital. Now that we have testing in-house, we're reserving the in-house testing for those that are admitted to the hospital and sending our discharge patients their samples to Quest. In terms of the other considerations that we're looking at for who we test and who we don't test, obviously those people with pre-existing medical conditions, looking definitely at their vital signs, their ambulatory pulse oximetry readings, what their chest x-ray looks like, and other social aspects, obviously, in terms of are they a sole caregiver for a dependent, the healthcare worker, one of our first responders that we need to be more vigilant about. In terms of our efforts to conserve PPE, right now, thankfully, and similar to as Dave and Jeff mentioned, we're part of a system, and the Inova healthcare system has a lot of resources and has a lot of leverage to gain more resources. So we're able to move resources around from facility to facility. But we are limiting right now our N95s, one per provider per shift. If we are entering an airborne precaution room, we are putting a surgical mask over the top of that N95 in an attempt to keep it clean. If that N95 is worn during a procedure that has been deemed like an intubation for high risk for aerosolizing the virus, we then change that N95 out. We are not discarding any of our N95s. Our system has been working very hard at collecting or creating the system for collecting N95, so we're not actually disposing them. So we can then disinfect, clean, the terminology of what we're actually calling it is still be to determined. But we are in the process of collecting those with individual labels so we can return them to the same user once they have been cleaned. We also have PAPRs available, and we are now deploying 3M 6000 respirators to our units like the ICU and emergency departments where there are high volume of use and on and off throughout the shift. As Dave and Jeff also mentioned, we're using iPads in the rooms to communicate. Our IT department has been extremely helpful in terms of creating some desktop portals that we can sit down at a desktop in the hallway outside the patient and call the iPad that's in the room and have a FaceTime discussion, which is helping us limit the amount of PPE that we're donning and doffing just to go in to update patients on their current results and plans. That's it.
That's it. That's a lot. Thank you very much, Carrie. No, seriously, thank you. That learned a lot. So one specific question: the presentations that you're seeing in your emergency department, presumptive COVID-19 patients.
Yes.
Have you seen on presentation patients with not just respiratory compromise, but also some of the other issues that we're talking about on the critical care rounds, coagulopathy, kidney failure, et cetera, or are they, when they present to you, they're at the point of respiratory failure, not beyond that?
You know, it's interesting. Most of the patients that we're seeing currently we've seen the gamut of everybody from those that walk to the front door and look absolutely fine, but by the 15-foot walk from the drop-off point to first look made their oxygen saturations drop to 89%.
Wow.
But yet they might be only mildly tachypnic, but they're speaking in full sentences and look from 10 feet away like they're doing fine until you actually pay attention to the numbers on their ambulatory pulse ox. And we're seeing, everybody from those type of look pretty well walking into the emergency department to those that are in, kidney failure. We've had a couple of investigated patients that are developing cardiomyopathies. We have a couple of patients currently on ECMO. So we're seeing the full gamut of those patients.
Thanks. I've got one more question. It's a specific question, and then I'm going to do the panelists need to be ready to go off mute because we're going to do lightning rounds really quickly with a few questions. Okay, and then over to Bruce for the polling piece, and then we'll finish up. So, Carrie, the question is, the question came from one of our participants. Using the plexiglass intubation box increases the concentration of the virus. Since the box does not appear to have a closed ventilation system, how do you manage the potential release of concentrated virus when you remove the box?
Well, so those intubation boxes are just meant to limit the direct exposure to the person at the head of the bed. It doesn't replace the patient being in a negative pressure room or any of the providers in that room being in an N95 level respiratory protection. It's really just meant to kind of limit the amount during the actual procedure. So I don't think it does anything to help limit the amount of virus that's been aerosolized. I think it's meant to be protective of whoever is doing the actual intubation even though they are going to be in an N95 level mask or PAPR or respirator still. They're still being kept in an N95 or a negative pressure room. It's not a replacement for that.
Thanks. We're going to open this up to panelists who have joined us. A sort of, it's a broad question, but your comments and insights on this. And much like I did on the recent rounds, I've mentioned before that we have a large number of rural hospitals, emergency departments, and critical access hospitals who are clearly participating on these rounds. And so Sharon, first Paul, and then Eric, about your experience with how your large center is connecting through interfacility transfer, and how you're working with those hospitals that aren't necessarily close by. Sharon?
By saying that it's a partnership really through our Georgia Department of Public Health. So I think our health department really partnering with the health department and identifying what the needs are throughout the state. Because while we are seeing positive trends here in Atlanta, we do have pockets throughout the state that might require some additional assistance. So it's really partnering with them to see what are their needs and how can we as larger healthcare systems in the city of Atlanta support them.
Thanks. Paul?
Yeah, I think we took probably a similar multi-pronged strategy. We have 2 hospitals on islands on Martha's Vineyard and Nantucket that are pretty hard to get access to and are quite small. We also have some more rural hospitals, at least rural by New England standards. And as part of our planning, we made sure that they had a degree of excess ventilator capacity if they weren't able to transfer, and we created telemedical linkages so that our ED physicians and our intensivists could reach out to them if they weren't able to transfer patients. But we also prioritize them above others that we work with for patient transfer if needed, especially for the critically ill patients. So thankfully, at the peak of our wave, we were able to support them through, and we think we're about at our peak now. And hopefully as that comes away, we'll be supporting more regular transfers. But we wanted to make sure that in the worst case scenario, if there just wasn't room at receiving facilities, they still had a degree of remote support and they had access to the supplies they needed. But the preference certainly is to try and help with transfer. We work very closely with transport services to, again, make sure those are the interfacility transports that we've prioritized.
Thanks, Paul. Eric, I'm not sure a question about rural and New York City matches all that well. So that being said, are patients actually being transferred from hospital to hospital, like to level load throughout the city?
Yeah, absolutely. It would be a far stretch to call any of our hospitals rural in New York City, but we do have community hospitals and we have level 1 trauma centers. And so across New York City Health and Hospitals, we've moved almost 900 patients to level load the surge, right? So to flatten that curve.
Okay.
So that, so absolutely. And we're working very closely with the city and the state OEM, as well as FDNY, our 911 system, to actually avoid the hardest hit hospitals and emergency departments, so that we don't have to do a transfer once you've already assessed and stabilized the patient. So looking to level load and flatten that surge.
I had not heard that before about the city. I mean, we haven't talked about that before in the rounds, but it's really gratifying to hear, like, not everybody's just having to stay and like take what's coming, but you actually are doing the level loading, which one would always aspire to, but hard to do in this situation. So with that, lightning rounds, and that's like, okay, everybody go, well, you don't even have to go off mute. It's raise hands, okay? And so these are ventilation support strategy questions. And so raise your hand for the panelists and speakers if your ED is doing high flow nasal cannula. Okay, interesting. 2, all right. And then, okay, which, yeah, double down. Next question, which of the panelists, speakers, EDs are doing PAP or BiPAP in your EDs? For COVID-19, I should have clarified. That wasn't fair. Do that again, how many? Okay. All right. And then how many are doing proning in the ED? 3. Okay. Fascinating. Still a lot. I mean, we're still learning a lot of variability, and we got like 3 months worth of a disease that we're learning about. So totally understandable, but fascinating to see those responses. I'm going to turn this back over to Dr. Strominger just before I close out. Bruce, you want to do the polling one last time here?
Great, thanks, Rick. And we are going to bring up the poll results. We had 141 responses. And as you can see, the majority, 65%, the PPE access has stayed the same. 23% have had an improvement in their access to PPE over the last 7 days, and 11% have had a worse situation with access to PPE. So thanks to everyone who replied to that poll, and we will integrate more of these in the future. Back to you, Rick. And also just remind everyone, please take advantage of the CME and CPD opportunities. There's a link in the chat, and that's how we get feedback from you on how to improve these sessions. Thanks to everyone.
Yeah, thanks everyone. I learned a lot. I hope every participant, panelist, and speaker learned from each other, just as these are designed as peer-to-peer learning. Really appreciate the participants, the panelists and speakers, Project ECHO, NETEC for all their support, and we'll see you on the next one. Thanks everyone. Have a good rest of your day. Bye.